look forward also at the end. I won't see questions in the chat probably as we're going, but at the end, if there's any, we have a few moments hopefully for some discussion, that would be great. So, and neither Dr. Bott nor I have any disclosures. So we're going to start this with a case. So VM is a 65-year-old female who's had opioid use disorder diagnosed for the past 12 years. And it comes from really a history of chronic musculoskeletal pain, which led to opioid use and subsequent misuse. She also has PTSD stemming from childhood sexual trauma. Her current medications include buprenorphine naloxone of 8 milligrams 3 times a day, baclofen, gabapentin, phenobarbital at night, and she reports being adherent with her medications, and this is also supported by her urine drug screens. She also attends supportive therapy. She has a medical history that includes breast cancer in remission, hypothyroidism, endometriosis. She's had a lumbar fusion ×3, which contributed to the pain initially. She lives with her female partner and has a supportive child. So there was a call that she was found obtunded in her home. EMS was called. She was administered naloxone twice and was transported to the hospital. And what happened in this case was she reported that she took 2 pain pills from her neighbor. She had been taking her buprenorphine and denied using other substances. In the hospital, she was needed additional naloxone, and she was discharged after a period of observation. So the presumed overdose was due to opioids. The UTOX there in the emergency room was actually negative for buprenorphine, positive for opioids. The patient was sent for 30 days to rehab. Restarted and remains on buprenorphine. And what was suspected was that this was a case where fentanyl had adulterated the opioid pills that she'd received from the neighbor. The fentanyl didn't come up in the UTOX that was done, being a synthetic, but the opioids that she had had a lapse to were detected. So just sort of one case to kind of go by of how difficult it can be both to detect the fentanyl in these overdoses and also how dangerous they can be. So we'll talk briefly about the epidemiology of what is happening in our country with fentanyl. So this is a graph which I think many of you have seen before. It's showing the 3 waves of the opioid overdose deaths. And, as you all know, we had a significant rise in prescription opioid overdose deaths during the first 2 decades, the first decades up to 2010. And then really when we saw less of the prescription opioids and more turning to heroin, we see this rise in heroin. But really this wave 3 is where we see the introduction of the synthetic opioid overdose deaths. And that's what's really rising significantly after 2015. And this includes fentanyl, tramadol, and so synthetic opioids that are not methadone. So really the number of drug overdose deaths decreased by 4% from 2017 to 2018. However, the number of drug overdose deaths was still 4 times higher in 2018 than it was at that beginning of that graph in 1999. And nearly 70% of the deaths, 67,000 deaths in 2018 involved an opioid. But there were some significant changes from 2017 to 2018 in these opioid-involved death rates. So what we saw was that the overall opioid-involved death rates decreased by 2%. Prescription opioid death rates decreased by 13%. Heroin death rates decreased by 4%. However, the synthetic opioid-involved death rates, again, that's excluding methadone, increased by 10%. And really, what we've seen even more recently is that from 2019 to 2020, they really hit an all-time high, so increasing actually by 21%. And so the CDC, you may have seen their advisory that came out in May that showed that highest period was ending the 12-month period in May. And of course, they're also relating that to the overlay with COVID. And that CDC advisory has really been prompting increased access to treatment and naloxone, early intervention, and improving detection of overdose outbreaks. So this slide is looking at New Mexico. So New Mexico's followed similar trends. What you can see here, this is looking at fentanyl and its analogs from 2012 to 2018. And I'm sure that this is going, if we followed this out, would continue to climb. And then you can also see a kind of corresponding climb of methamphetamine, because oftentimes, for different reasons, oftentimes both of these are involved in the overdose deaths. And this is looking, here's a female and male overdose deaths from heroin, again, from beginning of, so 2002 here to 2015, right? So you start to see that climb. This is kind of expanded out from that earlier graph. And with this, in this period of time here, basically you're seeing a six-fold increase in the total number of deaths due to heroin. But then came fentanyl. And this is really causing that increase to go up, as we saw, much more steeply. So fentanyl adulterated or substitute heroin, otherwise known as FASH, is marketed as heroin. However, it's 30 to 40 times stronger than heroin. And so this is really what's behind that significant increase. It's made illegally, so it's not diverted from pharmaceutical grade fentanyl, and oftentimes it's a multinational operation. So oftentimes ingredients coming from different parts of the world, such as China, India. They'll go to South America, is where a lot of manufacturing goes on of the fentanyl, and then it's sent up to where the demand is highest, which is here in the United States. So historically, the West, this green bar here you can see is the western part of the US, and this red is the Northeast, right? And here's the South. The West has historically been flat, but just here you're going to start to see that rise. And again, this is just going to 2017. And so I think if we pulled that out, that we'll start to see more of a rise there. Traditionally, I-95 up the East Coast was a major trafficking route, which explains a lot of more of the significant rise initially there. But New Mexico is not immune. So black tar heroin, which was more present in New Mexico traditionally, was harder to adulterate. But with the production of counterfeit pills, we've seen more here as well. And so this is showing in 2016 kind of the gradual spread. So you can see the higher levels along the East Coast, but making its way west. So then came the counterfeit pills, right? So this, I believe, is a press release from 2019 where the DEA seized this, in this picture, seen here, the pills by DEA Phoenix and Arizona law enforcement. So we'll just talk briefly about some of the clinical challenges with fentanyl. And really, we need a comprehensive solution because the challenges, as they often do, come from so many angles, right? So there's a need for a supply reduction, for sure. There's also a need for demand reduction. And I think that, over time, we've continued to feed sort of the opioid crisis here. And so addressing that demand is key. Certainly increased access to treatment is going to be an essential part of the solution. So thank you all for being part of that. And then there's also the question of fentanyl test strips for harm reduction. And there's been a couple smaller studies showing that having them present alters behavior to decrease risk. So an example of that would be if someone is able to test for the presence of fentanyl in their supply, then taking more precautions. So being sure never to use alone, for instance, in the case of an overdose, perhaps using less, knowing that that would be stronger. And then community resilience is also certainly, I think, a talk in and of itself. And community resilience, again, is that sustained ability of a community to respond to endure, and to recover from adversity. And this is going to be key, and will also deserves the attention of country and policy and all of us to help these communities that are most at risk and experiencing the most severe aspects of this epidemic. So along with clinical challenges, we don't know much about fentanyl. It's all very new. Kind of feels sometimes like when we're talking about COVID, we don't know very much. And so there's a lot to be learned. It's important to expect the unexpected. So things are not necessarily going to go as we think in any particular clinical scenario. It's important to remain curious, think of all the possibilities, and think of what might be helpful in terms of possible treatment that perhaps hasn't been tried before. And we'll look at that a little bit in the last few slides. It's important at this point just to assume that fentanyl is present, because we don't, most of the time, the urine tox screens will not pick it up unless you have a specific one in your clinic that tests for it, or you're sending it out specifically to the lab. And even then, there's oftentimes false there can be certainly false positives and false negatives. And so if you really are not sure, then you would need to add a test for confirmation. There are over-the-counter tests available that are FDA approved, but not CLIA approved. Another very frequent thing that comes up, which you've probably seen at this point, is oftentimes with co-occurring methamphetamine use, the fentanyl will be positive, and that's due to sometimes it not actually being there, but just a cross reaction in the screening test where it is making the test itself appear positive, even though fentanyl is not there. And then there are times when it actually is there and the person doesn't know it because it could be in their methamphetamine. And so that's also a very concerning finding, and something that can certainly increase the risk of overdose. So the other thing to think of in terms of a clinical challenge is that even though overdose can be effectively reversed using our naloxone and providing respiratory support, it might require multiple doses. And this should actually just say greater than, so sometimes requiring greater than 12 milligrams. So talk a little bit about how well do treatments work. And again, we don't have too much in terms of studies. There's a couple here that are cited that have been looking at this. So the Stone et al. Study from 2018. This was the first one, and I think the first bullet point there is referring to its findings. But it was the first study to look at outcomes with methadone maintenance and treatment of opioid use disorder in which people were using fentanyl, and 89% abstinence. It was a retrospective 6-month chart review of 154 charts, but it looked at how people did on methadone, and there were no deaths in those staying on methadone. There was 89% achievement of abstinence. There was a 57% relapse to fentanyl when on treatment. There's no difference in the treatment retention, but there's been shown to be slightly lower, although I think this Wakeman, we'll see in the next slide as well, Wakeman et al. Study from 2019 shows relatively similar opioid abstinence rates at 6 months in those who are treated with buprenorphine on fentanyl. And so these are two areas that are being looked at. Certainly, the other question is with naltrexone. We'll get to that hopefully in future talks as well. Induction can certainly be difficult with naltrexone, just like with shorter acting, with opioids such as heroin or opioid pain medications. It can be difficult. The long acting form, of course, is what's recommended for opioid use disorder. Right now, that's every 4 weeks, but possibly more frequent dosing. So every 3 weeks may be recommended. Again, in the future, there's no official recommendation for those who are on fentanyl, just because of having a greater effect and not wearing off over that last week. And then just remembering to, as with other opioid treatment, that sometimes methadone may offer some benefits over buprenorphine, for instance, because of its full agonist effect in the structure of the program. And you may need higher doses of methadone than you would expect. So for folks who you're treating who are on fentanyl. So for again, going back to naloxone overdose reversal, it works, it's key, but you may need to have repeated or higher doses. Also, the time window is shortened for being successful. So as always, calling 911 right at the beginning of an overdose. Often there's reports of at least 15 doses needed. So you might consider providing multiple doses for patients to have at home, especially if they're on fentanyl. So what's the role of buprenorphine, right? And this is why we're talking today. So most people are doing okay with inductions, but there are increasing reports of difficult with inductions, namely due to precipitated withdrawal. Again, this is that study from Wakeman that shows that really the Suboxone treatment retention and abstinence rates appear to be equivalent in patients who are on heroin versus fentanyl. And why do we see more precipitated withdrawal? There's no human human studies to say exactly, but there's some theories. So one is a reduced renal clearance, also the lipophilic nature of fentanyl being more long acting over time. I would say also just how we know how high of an affinity it has to that mu receptor, and so that is harder to displace. And interestingly, this with precipitated withdrawal is not seen when a fentanyl patch is replaced with a buprenorphine patch. We don't often see that unless perhaps in some inpatient settings, but occasionally this may come up as well in the outpatient setting. I'm not sure why that is. And when I asked Dr. Bott, he didn't say for sure the reason, but it's just something that's been observed. So because of this precipitated withdrawal, really the traditional approach, sometimes it does work, and we certainly hear cases of it working frequently, but also it's worthwhile to consider two different approaches that are being looked at and tried. So the first one is the microdose approach, and for this, I'll show you one case study here in a minute about this, but you're basically starting at a lower dose and going slower with your induction. And so it's a key to wait longer into withdrawal. So as opposed to waiting 12 hours, some are waiting for 24 to 48. This is key as well, is aiming for that higher initial COWS. So rather than waiting for the COWS score to be at least 8, you want to aim for 13 to 15. And importantly, self-report is not reliable really for a COWS score. And this is part of the reason why, if possible, doing these inductions in person may be more suitable. It's important to provide counseling and education as to what to expect, and providing adjunctive medications as you can with a traditional induction as well to help with any withdrawal should it occur. So again, medications such as Visceral for anxiety, ibuprofen for cramping, loperamide, diarrhea, things like that. And then this is really the speed that these inductions are recommended at. So 1 to 2 milligrams every 1 to 3 hours, and aiming to get to 8 milligrams twice a day by the second day, and knowing that they'll likely need to build up to a 24 milligram per day dose in most cases due to tolerance. And just keeping in mind that some may need methadone. So this is the 2020 case series here that describes this approach, and I'll show you on the next slide just kind of a couple of graphs depicting what happened. But in this case, there were 4 individuals who tested positive for fentanyl, and what the researchers looked at was a precipitated withdrawal that was observed in the conventional induction strategy, which was basically the 4 milligram and then 8 milligram, and starting at a lower COWS scale. And then the 2 individuals who completed the revised strategy where they did not precipitate this withdrawal, and their conclusion was that using the multiple, so that slow microinduction 2 milligram doses in patients who are already in significant withdrawal improved outcomes. These slides are a little, there's a lot going on in these slides. I had to look at them for several minutes to let it kind of absorb in, but basically what you can see here along these are your A, are the 2 who did these 2 participants did the traditional approach, and these 2 did the microdose approach. And you can see here was their COWS scale. Along here is their minutes, 0 minutes when they started their induction, and then following as the induction proceeded. And then along here is their Suboxone dose, which was essentially, we have the same scale over here as well. And what you can see is that for the 2 who had the traditional, they did not, but they were on fentanyl, but had the traditional Suboxone induction, when they received their doses of 4 and 8 milligrams, that did precipitate withdrawal. So their withdrawal, their COWS scale went up. And it did not with the waiting until they were in more withdrawal and then doing the microinduction. This slide is looking at Subutex versus Sublocade concentrations, and this is going to lead into the final 2 slides that look at the last approach, which is a macrodosing approach. But this is basically showing you here are your Subutex doses of 12 and 24, and then you can see the steady state for the Sublocade monthly injections. And basically, if you just kind of look across, here's the pharmacokinetic parameters. So looking here at the average, for instance, of a Subutex stable dose of 24 milligrams, it's actually a pretty significant increase in the amount concentration in the Sublocade when it's in its steady state. So I'm going to move just to the last, just in the purpose of time. I realize it's almost 12:30 and I want to leave time for our case. So go to the last 2 slides. Now these are looking at the second approach, which is the macrodose approach. And this is a case series out of New York from Mariani, and this was just published last year, I believe. And the next slide is an unpublished sort of subsequent part of the trial that that Dr. Bott had permission to show you all. But what this approach was, this is a case series looking at rapid induction onto long-acting buprenorphine injection for high potency synthetic opioid users. And it was a case series out of New York, basically spurred by the fact that in their research clinic, people who are on heroin had a 90% prevalence of the synthetic opioids. And the insert for the injection shows to be on at least the 8 milligrams of Suboxone sublingually for 7 days to establish that there's tolerance before transitioning to the injection. What these researchers were looking at was a quicker approach, basically also looking at the fact that there's high levels of tolerance typically in people who are on fentanyl. And they did start with a protocol where they were going to have patients be on 3 days of the initial Suboxone sublingually before transitioning, just to make sure that tolerance was established. But then they made that a little bit shorter to a 2 or 3 day induction, which is shown here. In order, because they were concerned about losing people really to follow up. And so what you can see here is that two people had on the second day their injection, and 3 people after they got up to the 16 milligrams, 24 and 8 in some cases, had it on their 3rd day. And they all 5 were inducted successfully, and they actually, if you look here, had relatively low COWS scores thereafter. And so what they then looked at, in this last slide I'll show you, which is what's still being worked on, but the outcomes here are impressive, was they looked at doing the 1 day induction. So basically providing the 1 sublingual macro dose of 24 milligrams, and then on that day giving the the extended release injection. So very high levels, as you could remember back to that slide about the concentrations. And you can see here that really the cow scores were pretty, for the most part, pretty low by day 2 and 3. And you can see the outcomes here, how many they had received, and no heroin use, intermittent heroin use in completing the trial, but they were successfully switched over to the Sublocade. So just food for thought. I think it's all, Sublocade. I know it can be tricky getting that medication, but I think that just knowing that this approach is being looked at, again, expect the unexpected, be curious, and bring questions here as well, because I think that we're all learning about this together. So.